Hello everyone. So managing steroids. First we're going to look at why we give dexamethasone for brain mets, but I think from the presentation so far we all understand that already. There is going to be a few repetitive slides that you'll see throughout the day, so just bear with us. It's just reinforcing the reasons. Prescribing steroids, discussing side effects, and looking at how to stop or reduce steroids. So we've seen lots of slides today, and apologies, these are just here in terms of if we're trying to look at, there are different types of brain mets, and it's just some examples of swelling. We've talked about when you see this, you're looking at that brain met, it's quite large, it's got mass effect, it's quite cystic involvement, but you can see the edema at the outside and the cause of the midline shift there. Again, other type of metastases. So there's your met there. There's some swelling there, but not as much. Here, multiple metastases. There isn't too much area of swelling there. And then here you've got metastases and there's a lot of swelling there. So they come in all shapes and sizes, and the swelling is variable. But also of note, size isn't important, as been touched on before. Even small metastases may cause disproportionate edema. Oops. So if we look here, there's quite swelling there, and here there's an awful lot of swelling there. So why give steroids for brain mets? Raised intracranial pressure and edema, neurological deterioration, and radiotherapy treatments which may cause or exacerbate the edema. We've already discussed, and Charlotte's discussed, and Dr. Whitfield, about whole brain radiotherapy. We're treating large volume areas. And steroids are often needed unless very small asymptomatic metastases. Or you've got high dose per fraction radiotherapy such as the stereotactic radiosurgery. Dexamethasone. So someone is newly diagnosed with brain mets and they're symptomatic. What usually we see is patients are prescribed dexamethasone 16 milligrams a day, usually 8 milligrams twice a day. And this is used to gain rapid control and test whether the symptoms are going to resolve. Once the symptoms have improved, we can start to look at dose reducing to reduce the adverse side effects of the steroids. And then smaller doses, so reducing doses and increasing doses for more minor symptoms, and we use that for less urgent situations. So you have someone newly diagnosed, symptomatic, we'll give high dose steroids. We'll start to reduce those steroids. For example, someone's from 8 milligrams BD, we start to reduce them, tend to reduce quite steadily. You can reduce 3 to 5 days, but if someone's quite symptomatic, I would look to more 5 to 7 days to start to reduce. If someone then, if you're reducing on a weekly basis, starts to develop symptoms, go back up. You don't necessarily need to go back up to the 16 milligrams, just the previous dose, and assess regularly. Divide the dose into breakfast and lunchtime. If we give the steroids in the evening or later in the day, it can cause problems with sleeping and affect the adrenal suppression. Or smaller doses, you can give up to 4 to 6 milligrams daily, in the morning once a day. Always ensure that a proton pump inhibitor is prescribed. Check blood sugars after each increase in steroids. So if we have someone who you've started to diagnose with brain mets, started on steroids, we would recommend checking the blood sugars, and when they're being discharged home on the steroids, refer to the district nurses to check the blood sugars. And what I would normally recommend is twice a week initially. If the blood sugars maintain below 10 10, just check them twice a week. If they go up to 17, monitor more closely and liaise with GP. And above 17 to 20, you'd start on medication. Also, steroids don't work for everybody. They work for the majority of people, but sometimes we see that steroids don't have any effect. And if that's the case, what we'd start to do is start to reduce down gradually. So the side effects of steroids we've touched on slightly. Diabetes, it's a common side effect of long-term steroids. Someone's having steroids for more than 2 or 3 days would always advise, because there is a risk of developing diabetes. Weight gain. Somebody who develops Cushingoid syndrome. So people can develop what we call a moon face, so they gain weight on the face and around the trunk area. Adrenal suppression, because the steroid is giving you that, the dexamethasone is providing that steroid, your own body's stopping producing its own. Proximal myopathy, that's the sort of muscle weakness, particularly we see it in the thighs. So we do see people who are on steroids over a length of time can develop quite marked proximal myopathy and really limits the mobility and can become wheelchair bound. And what we do see as well is increased risk of blood clot, PEs or DVTs. Insomnia, as I've mentioned, or agitation or psychosis. Increased risk of infection, plus or minus lack of fever with the infection. And that's sort of important to remember, because a lot of patients who will be coming and treated have the brain mets will be also having other treatments and may go on to other forms of chemotherapy. And it's just to be aware. Oral thrush, skin changes. People can develop acne, prone to bruising, sort of a thinness of the skin, and edema, and osteoporosis, bones becoming more brittle. So how do we manage these side effects? We want to ensure the blood sugars are monitored regularly, referred to district nurse and diabetic nurse if necessary. Prescribe prophylactic medication, so biphosphonates, for example, alendronate for long-term steroids to prevent osteoporosis. Prescribe prophylactic PPI, omeprazole and lansoprazole. And one of my personal challenges, if I'm seeing a patient, they may have been on steroids, they've stopped, but we've had to restart for some reason, is always remembering to make sure the PPI is prescribed. And prescribe medication for oral thrush if needed. In terms of the proximal myopathy, we referred to the physiotherapist, occupational therapist, for management of that in the community. Sarah and Julie, our neuro rehab AHPs, are going to touch that in more detail this afternoon. So I'm not going to say any more on that at the moment. Our aim is to reduce the steroid dose steadily and safely as we can to reduce the toxicities. It's important to provide patients with written information about the steroid use and the side effects, so that helps us when we meet them and we're assessing them, and they can give us feedback and update us on their signs and symptoms. And in case of DVT or PE, prescribe low molecular weight heparin. We talked about the adrenal suppression on long-term steroids. Basically, because we have in the steroids, it's failure to make your own cortisol. And what happens is if someone's been on long-term steroids over a while, your body's stopped producing its own. Even as you reduce down, it's going to take a while for your own adrenal gland to kick in and produce its own. So what we need to do is reduce steadily. Stopping steroids abruptly can lead to hypertension, collapsing or severe nausea or vomiting, hypoglycemia, seizure or coma. So suppression is a risk after only 2 or 3 weeks on steroids, and a lot of brain mets patients will be on steroids over that period of time, particularly if we've been talking about they've had some reactions to exacerbation of symptoms due to the treatment. Suppression is less when steroids taken in AM and when taken alternate days. And recovery occurs, but timing is variable. So how do we stop or reduce steroids? If we're taking steroids for 3 weeks or more, reduce gradually. How quickly depends very much on symptoms of brain tumour, treatment or raised intracranial pressure. Reducing symptoms, you can reduce every 3 days, between 3 and 7 days, allows time to assess the response of the reduction. Higher doses can be reduced in bigger steps initially, 1 to 2 milligrams. So say somebody is on 16 milligrams, you can reduce 2 milligrams every 5 days if need be, as I've mentioned before. But as you get to lower doses, if likely, then reduce by 1 milligram, 0.5 milligram steps. If somebody is still having symptoms, you want to do that reduction very slowly. There is no set reduction regime. It's very much on the individual patient. You may have a patient who you're able to reduce quite quickly and come off. You'll have others, you'll get to a certain dose point and then they become symptomatic. So you have to increase the dose. For those patients, what I would then do is slow down the reduction rate. You don't have to do it weekly. You can slow down by 0.5 milligram every 2 weeks and just take it, assess it regularly. And finally, for those patients who certainly have been more symptomatic and more sensitive to the steroids, I would convert to give the 0.5 milligrams alternate days to 3 to 4 weeks, then try to stop. Always letting the patient know, always warning the patient that if the symptoms worsen, go back to the previous dose. Managing steroids, it is a real balancing act. And that's the thing, you're very much dependent on the patient, the disease, the symptoms. So there are no set guidelines, and there won't be set guidelines for steroids because it's very much on an individual basis. So the principles of steroids, we all know, we start at the high dose and then try to reduce down as we can to try and minimise the adverse side effects. Thank you.